So thank you very much for the introduction, Heinrich, Ute, and the team, and for inviting us to join Apply Health Club today. We're really happy to be here with you all, and incredible that you're all dialing in from around the planet. So thanks for making time. We would like to share with you in this talk our personal but also professional journey to become care activists. And it's a journey that's still ongoing. But in preparing for today, we actually realized there have been 3 main chapters along the way, and that's what we're going to describe for you. And our hope is that this might trigger you all to reflect on your own journey as researchers and anthropologists and designers, and that we end up with a really rich debate around care activism and what it means to run a mission-driven practice. So really looking forward to your questions. Be active on the Padlet, and we'll make sure that we leave time to hear from you. So as designers specialized in healthcare, our knowledge of this domain has really grown very wide and deep over the last 20 years or so. And it encompassed or covered a lot of different health topics and conditions and diseases, but also different service lines. And we like to think of it in terms of everything from birth to death and all of the pit stops in between. So here on this slide, you see a number of different areas of care that we've worked on. And this experience has really grown by learning, working side by side with patients and family caregivers, different kinds of professionals from frontline care teams, and also healthcare leaders in different systems and countries. So it was really that experience of collaboration that built our knowledge.
So let's talk about our first chapter. And this started incredibly long time ago, 1998, and it lasted 10 years, 1 decade. And this first chapter for both of us was, we were part of Philips Healthcare, designing really medical equipment. And I would say this first, let's say 10 years was really about sort of like reframing designing products to designing service experiences. So how this became or began was that we, as designers, started to design these medical products, and we wanted to design them to be less threatening, more comfortable for patients, but also a better tool for all the care professionals who use this. At one point, we sort of realized that only designing the product was very limited. So we started to think about the experience. So this is about around 2000, where there wasn't so much of this kind of frameworks available. So we had this research project, and we really started to use or started to look at the overall experience. And we started to look at the patient experience across the different touch points. And we developed this research project that was called Ambient Experience, that is really trying to, in a way, design the entire end-to-end experience. Of course, this is where we started to use design research techniques. And this became, from a research project over the time of our Philips design period, became called Philips Ambient Experience, and is now a new sort of part of the business. And this one little project from this time we wanted to just show you is a pediatric CT examination solution that we designed, and it was aiming to help children to better cooperate with these very, very tricky examinations. So basically, these are just a scale model of a CT equipment in a waiting room with an interactive setup. When the kid is putting the toe in the mini CT, on the screen there is an animation showing there is a fish in the elephant tummy. So the idea here is really, we were sort of, when we were developing this solution, we worked with the radiology care teams, child psychologists, child life specialists, and they really inspired us to use the story telling technique. And this sort of like gave us the idea to develop this, this type of solution that will then really help children to deal with these difficult, children and parents actually, to deal with this difficult examination. And I think one thing that was very interesting, that at the time we were also doing evaluation on how this impacts efficiency and patient safety. And we really seen reduced throughput time, reduced sedation, increased satisfaction overall. So this is our first 10 years of our practice.
And then we decided to leave actually Philips Design together because we were uncovering insights that were not always being selected to be addressed by technology, or were not perhaps fitting to be addressed by a single brand, so by Philips, and even insights that could be addressed beyond the hospital setting or beyond traditional settings. So we felt that there was more that could be done based on the insights we were gathering, and we wanted to make a bigger contribution to transform healthcare experiences for people. So we decided to leave and set up our own healthcare specialized design consultancy called Fuel4, with the goal of wanting to address more unmet needs, work with a lot of different players in the healthcare system, so not just medtech, and look beyond just technology solutions. And so we began to expand our practice and innovation, and this slide actually shows some examples of how our methods and focus, I guess, evolved in that period of time. Bottom left is an interesting one. It's a project we did in Indonesia to look at what does wellness mean for Indonesians. And we developed techniques involving filmmaking alongside design research to create a series of insight documentary films that would be really compelling ways to bring insights into the innovation process and develop new products and services. We also were continuing with techniques like journey mapping that you see on the top right, that were basically gathering insights over time and building these end-to-end journeys as a way of understanding what's going on, but also mapping what interventions or solutions were possible. The image on the bottom was actually a project that we did for Samsung in their mammography service line. And it's illustration of doing observation and ethnography within mammography settings in Scotland and here in Catalonia. The image at the top, the hospital service design, and the one on the right with the innovative nuns are projects that allowed us to start working directly with healthcare service providers. So the Singapore National Eye Centre is that image that you see at the top, and we were looking at their diabetic retinopathy service and innovating improvements in patient experience there together with their team. And also in Singapore on the bottom right was a really key piece of work. We were invited to set up a design thinking and innovation academy in Singapore to train the healthcare sector in design thinking. When we received that invitation, we couldn't quite imagine that somebody wanted to train a sector. We said yes, and we went on an incredible journey of 3 years training different teams within Singapore and 2 more years training one of the main service providers there. Yeah?
Yeah, I'm trying to.
Yep. So while this slide, yeah, okay, you got it.
So this chapter was bringing us actually quite a lot of frustrations, and it took us 10 years to get to these frustrations. And I think we were really, we were growing. We had 2 studios, one in Barcelona, one in Singapore. We had like between 10 and 30 people team. We really started to sort of like be the victim of our own success in a way. And we were really in the end dreading going to work to a company that we actually started and we were running. So something was really, really bad. What we felt amongst our frustration is, this is just a few that you see on the picture, that we felt that we constantly needed to convince people who we work with of the value of the work that we are doing, therefore wasting lots of our energy in doing so. We were really trapped in this client-supplier mode, which is really determine the kind of relationship you have. In a way, it's a very kind of transactional relationship. We really expected to deliver and leave. So as consultants, you deliver your deliverables and then you don't see anything about it after that. We were also facing the hardship of growth. Growth is not easy. And if you are maybe not there for the financial growth it's maybe even more difficult. And this was certainly very hard for us. We were missing the hands-on content. As business partners, we did less and less, and that was not very good for us. And then we also realized that our practice was really mainly problem solving. And that was also, we felt it was quite a narrow space. So the 10K Clarity Run, this is quite a personal moment in this presentation. So all of this, we were in our head and mindset. And we were really reflecting and discussing a lot, what do we do? And I went one day to a run. This is my normal run in Barcelona. Don't look at the timing. But basically in this 10K run, I had every maybe 2 kilometers, I had a realization. It's kind of like was hitting me some of the insights that we were already thinking about. So one of maybe the first insight was that maybe we are crappy consultants, because we always had our agenda from the very beginning, from chapter 1, chapter 2, we had our own agenda. We always tried to imbalance the disparities between power in healthcare. So I kind of realized in this that what we are really, as a practice, we are more like activists than consultant. Then the next 2K was, maybe I realized something about that as designers, we are actually kind of separating us from our partners because we are strange. So the connection point was actually not very strong. So that was also a very interesting kind of realization. Then, of course, related to the energy, that we shouldn't work with people who are not convinced. We should work with people who are convinced, and we should work with people who want to do the same thing what we want to do. So then we can put the energy on the right thing. And then maybe the last thing that it became very clear also is that by focusing on healthcare and sort of like we realized that we are in the same silo with all of our partners or used to be clients, where actually some of the innovations that we are trying to help them with is to connect outside of healthcare. So for us to be in the same silo with them was also limiting. So it was quite a run. And we then basically discussed and decided to change our practice.
So in 2017, 18, in this period, we hit the pause button. Many people were shocked because, like we said, the business was growing and was successful. But I think our friends and partners who knew us well saw that this was needed and that this was a fresh start. In that year, quite tellingly, I think I slept for about 6 months and he snowboarded for about 6 months because we have very different ways of recharging ourselves. And we woke up and kind of came back refreshed, and having reflected on the 20 years of work, we actually landed on 2 projects that we call beacon projects, because they really shone a light on the way forward. And they are the Hospitable Hospice, the Blue Book, and Who Cares, the Yellow Book. The first was about reimagining end-of-life care in Singapore, working with 3 hospices. And the Yellow Book was about looking into the experiences of family caregivers and uplifting their experience and supporting them in their journey. So these were 2 projects that stood out against all of the years of work, because they were each 9 months long, which is the time it takes to have a baby. So that was a really good length of time to bring this, these topics and these ideas forth. They allowed us to really deep dive and really to deliver outputs that made structural impact. So Who Cares shifted policy around caregiving in Singapore, and the Hospice Project enabled 3 new buildings and services to go up. And so both of these topics were actually quite at the edge of healthcare, palliative care and end-of-life care, but also social care. Was a first deep dive for us into the social care landscape. And so, as László was mentioning, as we realized that these were the projects that had the most meaning and power in some sense, most impact, we decided to reframe our kind of practice and focus on care as a transversal topic, and also look across the silos of healthcare, social care, and education. And our experience in Singapore made us really picky. We said, this was the work we want to focus on. This is what we want to dedicate our energy to in the next decade. And so we set up the Care Lab. This next slide was built through that reflection process. We're now chapter 3 and started in 2018. And it was a chapter driven by Care Activism. So to come up with what you're looking here is an action framework that actually guides our work and our practice. And it emerged by simply taking all of the different projects we'd done in those 20 years and mapping them, not by what we were doing or what was the deliverable, but by the underlying intention. And when we did that, we realized that there were 7 different lines of action that we believed we could make a contribution as designers in order to transform care. And so see this as a landscape of care, and see these 7 topics as kind of almost acupressure points where you can push the system to transform the system. And so we use this framework as a team to scope our projects, to find partners, but also to communicate the mission and vision as the Care Lab. I'm not going to go into it in detail. On our website, you can read about each one with examples behind each one of these. But usually the best way to read this image is starting in the center, 2 different lines of actions that are really looking at the basic human interaction in care. So between a professional and a patient, or a teacher and a student, a social worker and a client, we look at how might we normalize care conversations and make those interactions, as László was saying, without the disparities in power, but make them equitable interactions. We look at how can care be designed together, so pulling those stakeholders to actually create the tools and conditions for that kind of conversation to happen. And then it's nice to kind of zoom out to the right-hand side, where we look at those participating in care. So what does it take for people, ordinary people like all of us, to engage in our own care? And then if we put ourselves in our communities out there, then how does care actually fit into our neighborhoods, into our social networks and communities? And over to the left, if you want to have this equitable, compassionate conversation between a professional and a person, you need to think about how are we training our teachers, our doctors, our social workers, and empower what we call a new breed of care professional. And for them to exist and to be able to connect with the clients that they serve, they need to be supported by their organization. And so nurturing, caring environments and organizations is also creating that professional context in which these kinds of care experiences can be held. All of this together, pushing on all of this together, allows us to work on a more societal level of actually breaking some of the taboos and stigmas that exist around care. So being able to talk about death and dying, being able to talk about end of mental health and issues that no one as a society really wants to touch. So with the setup of the Care Lab, and we'd explained our frustrations, this was a chapter in which we really made a conscious shift to move from the consulting model that had made us feel unwell to a mission-based practice and to operate as care activists. And so instead of this convincing energy put to convincing clients, we wanted to partner with groups and organizations that have shared have a shared vision and mission and values. We also wanted to work within the action framework that we'd set up. And so aligning around one of those 7 topics already gave us ground to collaborate more strongly. Our attitude changed. We didn't wait for the kinds of briefs that we wanted to get. We were proactive in saying the topics and challenges that we believe we want to work on, and then finding partners who group around that. We became increasingly, and we are advocating for specific causes. And so we stay with topics longer, and we find different ways to push them and to challenge them over the years. We've also found that we can bring a certain level of power to conversations, and that we have a point of view, we have a mission, and it helps to then be able to stand that ground and to actually negotiate and frame and define projects that are going to transform the things that we care about. And finally, shifting from problem solving to problem caring, which means, for example, with the hospice work, which began 10 years ago, we continue to journey with that and care for that as a challenge and a problem in our societies, and find different ways to work with it. So this slide just has a few examples of the Care Lab and the programs and projects that we are doing. I'm not going to go in detail because we want to dive into one of these with a bit more insight for you. On the top left, we're involved in a social movement, political push here in Catalonia to establish a national system of care. So that's really a grassroots and ground up activity that we are partnering with a lot of different organizations, academics, public administration, but also grassroots organizations on this. The image on the bottom left and the space that you see at the top comes from the same project with a leading hospital here that we've been designing with architects, a new pain unit, and developing service tools to support the first conversation that a patient will have with pain unit doctor around their chronic pain. We're trying to shift from consultation to conversation with that project. We just finished earlier this year a project with the NHS to look at system transformation around heart failure. So that's also a system-wide project to optimize patient experience and care delivery around heart failure for one particular region of the country. And over in Singapore, we have a dementia care model that we're developing that is community-based, together with the Lien Foundation and an elder care service provider. And we also joined forces with different other activists and networks. So the Patient Revolution, I encourage you to check out, is one of our partners, also pushing against the industrialized model of healthcare in the US.
So one of the projects we would like to show you a bit more in detail, not super high resolution, is this project that we started to do, started in 2019, and we partnered up with a radical philanthropist and a hospice provider organization in Singapore to really redesign a daycare hospice model. and design a new service with this new model. So we started with the visioning step, and it was really to find a common vision amongst all these different partners, including the care team. In this case, we partnered up with an architect practice, but also the radical philanthropist in a very collaborative way.
Getting inputs from the ground and from all the different partners involved in the project, we translated that then to an overarching service strategy and a positioning for this day hospice service. It would be called Oasis, and the idea is that it represents a place to grow. And that means for patients at the end of life, their families, also the staff working there, and volunteers who are coming through. And around this positioning, we developed this set of 6 service rituals. And the idea of a set of rituals is that it provides a quite open framework for teams to deliver services, but also to keep ongoingly innovating and adding new services over time. So it gives them a consistent, coherent framework of the experience qualities that they want to offer, but it gives them room also to continually create their own rituals and practices moving forward. So from that original visioning step, we then began to detail out very specific service ideas that you see on the left, storyboards and concepts for services that would enable this kind of growth at the end of life. And one step that we did in this project was to invite members of the team, of the care team, to become what we call service parents. So it's this idea that they would pick services that they'd been involved in co-creating and say that they want to be the mum or the dad or the grandma, the grandpa to this idea, and that they would be involved then in developing and nurturing and growing up this service. So we had co-parenting of all of the different services that would be introduced within Oasis.
One of the example is we develop many different tools and protocols and services. One of this example is the Wheel of Life. It's a conversation trigger tool the social workers can use to really start their patient and the family explain their context. And it's a very collaborative and very physical tool to put some of these issues on the table. And then you can see this is a little bit of what it became. The Oasis opened in 2022. It's really a very different kind of service. It really feels very differently. It really focuses on the development of everyone involved. Usually the story would end here, but not with us.
So as the service launched, I mean, typically that as consultants, you would probably, that's the deliver and leave moment. But we stuck around and we're on a journey with them for a further 2 years. And the beginning of that, what we call gardening period, which is staying around to really nurture and establish some of the new practices and solutions that they co-developed. The first step was creating a new job description and role. So they have a service experience officer now defined as a specific role in the organization. This is something unheard of for the sector. It doesn't really exist in the long-term care sector to have this kind of role. And so they wanted to make that an official responsibility in order that somebody could oversee and lead and continue to lead this transformation. Some of the solutions and tools that we developed were also for the care team themselves. And so in this gardening period is very much about coaching the frontline team, so the social workers and the assistants, but also the nurses and the clinicians. And this is a toolkit called Caring Practices for them to continually have a habit of stopping and reflecting on their experience delivering care and creating a safe moment in which they can share what they're learning amongst themselves as a team, with the idea that if they don't feel well, they can't transmit and offer the kind of care that they want to their patients.
And then we are basically with the team to help them to really adopt these new services and this new way of working and adopt the culture of being careful and kind with the clients, but also amongst themselves. And this is the step, which is the caring organization. In these 2 years, we are coaching them and we are gardening this team to really become a different kind of organizations altogether. So this is the little case study that we prepared, and we would like to just sort of like leave it here. Maybe just one more thing is that as care activists, we don't only care for projects, but we care for care as well. So we are really interested in bring this topic and discuss this topic in society. We ask you to leave some of your reflections before this call. We invite you, if you didn't, to do so. It's whatiscare.org. And there are some really, really interesting definitions. Thank you so much.